Hello, good evening, friends. Today we are going to talk on one of my favorite topics, that is primary and secondary amenorrhea. Let's straight away jump into the topic without wasting much time. Before I proceed to all the postgraduates, I want to tell a general formula. That is, gynecology means menstrual cycle and menstrual cycle means gynecology. You should be thorough about it. And to understand menstrual cycle, I always explain in broader terminologies that two systems should work hand in glove for a normal menstrual cycle. And I call them a central system, which consists of hypothalamo-pituitary ovarian axis. Even though ovary is in the periphery, that is in pelvis, I consider it as ambassador of the central system. Then there's a peripheral system, which consists of uterus, cervix, and vagina, intact vagina. Now, these two systems, only when they are in perfect harmony will there be normal menstruation. Among them, one decides about the cyclicity, obviously the central system, because it is in the brain. Uterus doesn't have the brain, and uterus is in a way subservient. It decides amount and the flow. If there is problem in one of them or either of them, there can be abnormal menstruation, including amenorrhea. Now, when I say primary amenorrhea, right from the beginning, she never had menses. So you have to think of drastically wrong with either of the systems. As drastic as there is no uterus, or the vagina is not fully formed, or there is something wrong with the cervix, cervical atresia congenital, or even as drastic as hypothalamus is not working at all, or maybe the pituitary is having some problem, hypogonadism, or ovaries are not there. I hope you understood what I mean by this. So primary amenorrhea means both the systems or either of them have not been tested at all. Whereas in secondary amenorrhea, you can't think as drastic as that. They have proven that they have worked before, but something happens along the way and then the menses stop. So with this much of broad understanding, let's go and understand these things. It's a very, very fascinating subject. And it's a very important topic, both in theory and in practical exam. If there is a case of amenorrhea, primary or secondary, it will be definitely kept for the exams. And it's very easy to score in them. Definition wise, there are many definitions. Many age have been defined, but this I found as more practical as well as accepted by many. Failure of onset of menstruation beyond the age of 16 years. Easy to remember also, sweet 16 we used to say. So 16 years, if somebody has not menstruated, you can call her having primary amenorrhea, regardless of the development of secondary sexual characteristics. What does this mean? Usually, if a person has, or if a girl has secondary sexual characteristics, means there is some amount of hormone secretion, and they are like forerunners of menstruation. The definition says, regardless of that, if somebody has not attained menarche even by the age of 16, you can call her as having primary amenorrhea. But when to start the workup? If by age 14 years, menses has not occurred, but the onset of puberty, such as breast development, is absent, a workup for primary amenorrhea should start, because there's no point in waiting. You have to search why there is no breast development. What is the problem? On the other hand, in the presence of secondary sexual characteristics, as I told you, They are the forerunners. Investigations may be delayed until 16 years. In the other words, you can sort of counsel the parents and reassure them that, look here, the secondary sexual characters have already been shown here. That means the ovaries are producing estrogen, and it's a time that uterus may respond and she will have menses. The detailed evaluation is very, very important. The growth charts that will tell you whether there has been a delay right in the childhood. Height and weight records. This will help us in actually diagnosing few things. For example, Turner's. Chronology of development of secondary sexual characteristics. This is very, very important. And this is also a MCQ question in many, many entrance examinations for undergraduates, especially. Thelarchy, adrenarchy, and finally menarche. That's what I said. Thelarchy is breast development that occurs first. Adrenarche is other secondary sexual hair, and finally culminates into menarche. So thelarchy and adrenarche are the forerunners. If they are there, you can be almost sure that given time, she will menstruate. Body habitus, whether she's obese, whether she is the tall, whether she's short, and what kind of features are there, all these things are important. You will soon realize why I'm saying so. History of cyclical abdominal pain suggests that she is having cryptomenorrhea. That means she's menstruating, but it is hidden inside. That's why she's having cyclical abdominal pain. That shows that there is an anatomical problem and rest of the systems are okay, probably an easy case to tackle. History of tuberculosis, very rare in young girls at that age, but it can still happen. And thyroid disease, juvenile diabetes, and mumps. Mumps is the one which can destroy the ovaries. But usually these causes are that of secondary amenorrhea rather than primary amenorrhea. Physical examination is important. As I said already, stature, what kind of a stature she has got, and height and weight ratio. It will help us in diagnosing Turner's, Klinefelter's. Turner evaluation, Tanner evaluation of maturation status of secondary sexual characteristics, both for breast and pubic hair. All of you must know this. Usually we say Tanner's 4 should be there. Genetic and endocrine stigmata, whether there are any evidence to suggest that she has got an endocrine problem or a genetic problem. Presence of vagina and uterus. You can actually do examination very gently with the permission of the parents if you want, or if the person is not willing, then you can go for ultrasound. Investigations to be done. I usually ask this question to the students. What's the number one investigation you want to do if you are dealing with a case of primary amenorrhea? And usually students answer in chorus, and that is FSH. FSH is the number one hormone that we have to test. Of course, the second one is estradiol. Now, FSH tells us whether the starting point, obviously hypothalamus and pituitary, are doing their job. And based on the masters, the ovary will respond in terms of estradiol, and rest of the orchestra will go on. So these two will form the first two investigations. In fact, the classification of primary amenorrhea is based on the level of FSH. I'm soon going to talk about it. Prolactin, as you have heard in my earlier talks, they are all close cousins. FSH, TSH, prolactin, estradiol. When they are cousins, if one is affected, other one is also affected. Yes, there you are, TSH, testosterone, RFT in select patients, because if there is a uterine anomaly giving rise to the primary amenorrhea, 1/3 of the cases or 30% of the cases will also have renal anomalies. So RFT is important in such patients. Radiological evaluation of bone age. Sometimes the parents may not know what is her age, so you may have to determine before you jump into any conclusion or branding her as a case of primary amenorrhea, because it is really, really very distressing to the patient as well as to the parents. X-ray skull MRI to rule out pituitary macroadenomas. Other day I was taking class on prolactinoma or hyperprolactinemia, which is a very well-known cause for amenorrhea, including primary amenorrhea. Karyotyping is extremely important if FSH is more than 40. What does this mean? There's something wrong with the probably production of the estradiol from the ovaries. That's why in an attempt to beat the ovary, the pituitary is secreting more of FSH. Maybe we are dealing with a streak gonad. Streak gonad means Turner syndrome. Turner syndrome, how do you confirm? By karyotyping. 45X0. So FSH is the hormone among all the hormones. So I have highlighted that. Now, as I promised, the classification based on FSH. That is the first hormone to be estimated, and based on that, you can classify theoretically the primary amenorrhea. Hypergonadotropic, that means FSH is more than 40, estradiol obviously less than 40 picograms per ml. So only when the estradiol is less will the pituitary be alerted to secrete FSH. All of us know from the normal menstrual cycle. That's why I right in the beginning told, if you want to understand gynecology, you have to understand the menstrual cycle better. Estrogen and FSH have got a feedback system in such a way they have a negative feedback. As the estrogen increases, it will give a negative feedback to the pituitary saying that enough of FSH. But if the estradiol is less, there's a positive feedback to the hypothalamus. It will secrete GnRH and tell the pituitary to produce FSH. So here is a situation probably where pituitary is producing more FSH, obviously because of less estradiol. And what is the reason of less estradiol? It could be because of an abnormal sex chromosome, that is 45XO, as I just said, Turner syndrome. Or it could be mosaic and abnormal X also, what is called gonadal dysgenesis. The problem is when it occurs in a normal sex chromosome, difficult to understand, but not really. The possibilities are pure gonadal dysgenesis. It can occur in 15.4% of the cases. Here, as you can see, chromosomes are normal, but gonads are dysgenetic. That's why it's called pure, in the sense, as far as the chromosomal purity is concerned, it is 46XX, but there is the dysgenesis of gonads. The other one is Savage syndrome. Savage in the sense, in the olden days, the meaning of savage is old, isn't it? So it's something like we are primitive animals. As you know, in primitive animals, they don't ovulate every month. Only sometimes they will ovulate. Similarly here, probably the gonads are such, they are resistant to gonadotropin. That's why they don't produce eggs at all, and there will be amenorrhea. Then we have what is called 46XX or XY Swyer syndrome. There also there will be problem, 3.4%. Now it's easy for you to understand 46XX Swyer syndrome, but why should 46XY, which is male, have a Swyer syndrome? Why do we talk about that? To understand that, you need to understand this. Swyer syndrome is because of a deletion of SRY gene. I'm going to talk about this in another talk when I talk about the DSDs. SRY gene is more important than Y chromosome. So if a person has no SRY gene, it results in XY, but female. See, this is a perfect XY chromosome. And that blue band is the SRY gene, which totally dictates a fetus to become the male. Now, if a person does not have that SRY gene, here see no SRY gene, then even though the person has got XY chromosome, it will be like a female, Swyer syndrome. So ultimately, you have to remember only 3 syndromes, or rather 4 syndromes: Turner's with the abnormal chromosome, pure gonadal dysgenesis, Savage syndrome, and Swyer syndrome, to give rise to hypergonadotropic problems. Obviously, it means gonads are, that is, ovaries are not working. Pituitary is working extra time, overtime. So the next one is eugonadotrophic. U means normal, euthyroid we say, eugonadotrophic. Now, easy to remember, U means uterus. There is something wrong with the uterus. Absence of Mullerian development maybe. Here, ovaries are fine, pituitary is fine, obviously hypothalamus is also fine. They are doing their job, but there may not be uterus at all. Absence of Mullerian development. This can happen if she is a female proper with XX chromosome. The only possibility is Rokitansky-Kushner-Hauser syndrome, what we call RKH syndrome, Mullerian agenesis or absence of uterus as well as sometimes vagina. But if it is a male karyotype XY, it is testicular feminization syndrome, or the other new terminology is androgen insensitivity syndrome. Very easy. So U means uterus, eugonadotrophic. Nothing wrong with the HPO axis. Or suppose there is normal Mullerian development. That means uterus is there. You have to think of female or true intersex, or adrenal or thyroid disease outside the system totally. That may be the cause of this particular situation. This could be a female. In an intersex, what happens? One ovary is normal, that is producing enough estrogen, and that is giving rise to normal FSH, whereas the other ovary may not be functioning at all, not good enough for a proper, menstrual cycle. So EU, uterus. The next one is cryptomenorrhea. Here, uterus is present, but there may be obstruction in the form of imperforate hymen, vaginal septum, or totally a different problem, that is tubercular endometritis. As I said earlier, in very young girls, tubercular endometritis is very, very uncommon. And usually tuberculosis is talked about in the secondary amenorrhea rather than primary amenorrhea. Now comes the third variety, hypo. First, I talked about hyper, wherein you can blame the ovary. Then I talked about you blame the uterus. Now, ovary ho gaya, uterus is over. When it is hypo, who is left? You have to blame hypothalamus, hypophysis. So that means either hypothalamus or pituitary you have to blame. It is so easy and fascinating, isn't it? Don't you feel so? Hyper, ovaries problem. Uterus is problem. Hypothalamus and hypophysis, that is pituitary is our problem. So here FSH is less than 10 milli-international units per ml. So hypothalamic causes delayed menarche and puberty, which may be some sort of a constitutional. Hypothalamic hypogonadism, Kallman syndrome. Psychogenic causes like weight loss, stress, anorexia nervosa, malnutrition, they all work through hypothalamus. And hypogonadotropic can be like pituitary causes, underdevelopment, which will manifest like short stature, obesity, genital dystrophy, mental retardation, polydactyly, retinitis pigmentosa. Neoplasms, prolactinomas, as I told you in the hyperprolactinemia class, craniopharyngiomas, adenomas, empty cella turcica. Hypopituitary states like Simon's disease, Chiari-Frommel syndrome, Fob-Albrecht syndrome. if people complain that there are not enough syndromes in gynecology, this is the chapter where you have enough and more syndromes. Then comes severe systemic disease like tuberculosis, not of the uterus now, tuberculosis of the meninges, and which will affect the production from the pituitaries, syphilis, again the meningeal. Other endocrine disorders like thyroid and adrenal, these are the cousins of the other hormones, FSH. Having understood the classification from the point of FSH, now it is imperative for us to understand the classification based on secondary sexual characteristics. Clinically, how do you classify them? Clinically, you classify as normal secondary sexual characteristics, which obviously means that ovaries are there, good, and producing enough estradiol. Then you have to think of problems. Maybe it's a constitutional delay. Imperforate hymen, you have to think only of anatomical causes now, or transverse vaginal septum, because HPO axis is perfect, showing its beautiful, robust hormonal maturity. Maybe absent vagina or functioning uterus, or maybe absent vagina and a non-functioning uterus, or XY female who is having no uterus at all, androgen insensitivity syndrome or RKH syndrome, rarely resistant ovarian syndrome. So this is clinically thinking. Normal secondary sexual characteristics, blame anatomy. Absent secondary sexual characteristics, what does it mean? There's no estrogen. So it is further divided to normal stature. You have to think of hyper or hypogonadotrophic hypogonadism, or acquired, which works through hypothalamus, weight loss, excessive exercise, things like that. If she is short stature, obviously, it is hypogonadotrophic. Congenitally, hydrocephalus may be the cause. Acquired could be trauma, or hypergonadotrophic, which we have already understood as Turner syndrome. The next one is heterosexual. It is neither totally female nor afeminine. It is masculine. Congenital adrenal hyperplasia is the leader here. That is the problem. Androgen secreting tumors, whenever there are heterosexual, like hirsutism, hair, or hoarseness of voice, you have to think of these things. 5-alpha reductase deficiency, partial androgen receptor deficiency, or true hermaphrodite. All of them can cause, or absent Mullerian inhibitors. They will cause amenorrhea. So according to location now, a third way of looking at it. First way from the point of FSH, second way clinical point of view, and the third way location is. Whichever way you look, even if I shake you, there is absolutely no scope for confusion. If you start from the genes, genetically, delayed puberty, constitutional, familial. Then from genes, you go a little higher to the chromosomes, intersex, Turner's, testicular feminization syndrome. After that, you go to cerebral cortex. It could be stress, emotional disturbance, infection, trauma, tumor. They all work through the hypothalamus. Hypothalamus per se, Kalman syndrome, vigorous exercise, weight loss. Come down to pituitary, empty cellular tursika, Cushing's, pineal tumor, prolactinoma, Frawley syndrome. It's somewhat like repetition, but looking from different angles. Then you finished with the pituitary, come to ovary, Turner's, Savage syndrome, Sware syndrome. These are the three syndromes I told you right in the beginning. Then come to genital tract, absent uterus, refractory endometrium, obstruction of the lower tract. Endocrine, juvenile diabetes, thyroid, adrenals. Drugs, tranquilizers, antidepressants, antihypertensives. Nutrition, overweight, underweight, malnutrition, weight loss. The best approach is a clinical approach where you consider everything. It's almost like a summary of whatever we discussed so far. Patient type, breast absent, uterus present. What does this mean? Lack of breast means lack of estrogen. So that means HPO failure, which means Turner's, XO. Presence of uterus means there is no Y gene. why SRY is not there. Y chromosome is not there, SRY gene is not there. So how to distinguish now? You estimate the FSH. If FSH is low, then of course it is a HP failure, hypothalamus or pituitary failure. If FSH is high, ovarian failure, Turner syndrome. So easy, so logical, so mathematical. Now to differentiate whether it is hypothalamus or pituitary, if somebody asks you, you can't simply say HP failure. Which one of them is failure? Do GnRH stimulation. When you give GnRH, if LH rises, that means hypothalamus was not doing its job. After all, its job is to produce GnRH. But in spite of giving GnRH from outside, if there is no LH production, who is at fault? Pituitary is at fault. So mathematical. The next variety is breast is present. Now ulta, completely opposite. Breast is present, uterus is absent. Now, breast is present means what? Enough estrogen, ovary is there, ovary is being nicely taken care of by hypothalamus and pituitary. HPO axis is 100 mass, no problem. But uterus is absent. Two possibilities only. If she is purely female, Arcade syndrome. Otherwise, it is testicular feminization syndrome. So easy. Now, how to distinguish? Testosterone estimation will clearly tell you in testicular feminization syndrome, it is in the male level, whereas in Arcade syndrome, it is in the female level. Last one, very unfortunate situation. Breast is absent, uterus is also absent. Lack of breast means lack of estrogen, gonadal agenesis. Lack of uterus means maybe there is presence of Y chromosome and SRY gene. Karyotyping is the only answer to differentiate between them. If it is 46XY, it is Turner's. Serum testosterone will be in the female range. Management is very important. Just understanding theoretical classifications and what is the cause is not important. Patient, after all, wants management. Tell me what I should do. Parents are concerned about that. If it is hypergonadotrophic, obviously you know that ovaries are at fault. Do a chromosome study to prove that she is a case of Turner's. But if you find it is XY person, then you have to unfortunately advise gonadectomy, vaginoplasty, estrogen, or a supplement, and adoption is the only answer. If it is Turner's, you can give cyclical estrogen progesterone to promote feminization and prevent osteoporosis. But as far as fertility is concerned, oocyte donation is the only answer. Luckily, she has the uterus anyway. If it is XX, little bit difficult for the patients to understand. You have to think in terms of ovarian resistance, Weir syndrome, or a Savage syndrome, where there is deficiency of FSH receptors. So you have to think of giving that. Savage syndrome receptor defect, both of them may be treated like XO only. No point in giving more and more FSH. It is something like pituitary beating them. So we have to consider cyclical estrogen progesterone to promote feminization, to prevent osteoporosis, and oocyte donation for fertility. If it is eugonadotrophic, on the other hand, we know that eugonadotrophic means uterus is problem, chromosomal study. You can say if it is testicular feminization, XY, that's why uterus is not there, gonadectomy, vaginoplasty, estrogen adoption. If it is female, it is a case of Arcade syndrome. 30% have renal skeletal abnormality, creation of functional vagina, surrogacy is the only answer. But if you have Dr. Puntambekar around, he will consider uterine transplant. With cryptomenorrhea, if that is a problem, hymenectomy, vaginoplasty will solve everything. Hirsutism is present, mechanical removal is important, anti-androgen should be given. It may be a case of adrenal hyperplasia. Hypogonadotrophic, where the gonadotrophins are at shortage, you have to give them FSH and HMG therapy. Hypothyroidism coexisting, thyroxine should be given. Pituitary tumors are there, surgical removal to bring down the prolactin. Hypothalamic and pituitary dysfunctions, you have to give them cyclical estrogen progesterone because uterus is there in them. For fertility, there is no need of ovum donation, but ovum induction, ovulation induction using HMG therapy. Nutritional manipulation can help some of them. Now I turn to secondary amenorrhea. I spent a lot of time in primary amenorrhea because that's one difficult to understand. But secondary amenorrhea is much easier. So I hope to finish in next 10 minutes. Definition: amenorrhea of 6 months or more in a woman with previous normal menstrual cycles. The apparatus has been tested. HPO Hexis has shown that it has working capacity. In the absence of pregnancy and lactation is very important to underline and understand. What's the etiology? Now you talk in terms of only problems from genital tract onwards. Genital tract, acquired cervical stenosis. Because this genital tract has shown that it can menstruate, something has gone wrong later. What is the cause? Maybe amputation, as in case of Fothergill's operation, conization, a vigorous one, or tuberculosis that has blocked the cervix. If it comes to uterus, go one step up, Usherman syndrome. Here, you will not think of vagina because imperforate hymen is a cause of primary amenorrhea, vaginal septum is primary amenorrhea. Those two are ruled out. That's why I start with the cervix. Usherman's, maybe because of vigorous DNC. Nowadays, we don't do DNC at all, but if still somebody is doing. Resection of endometrium, maybe for a menorrhagia, somebody would have done it very harshly. Or tubercular endometritis. Now go to the ovary next. I'm starting from below here. Go to the ovary, maybe infections, mumps, or TB would have destroyed ovaries. PCOS is a very well-known cause of secondary amenorrhea. Ovarian resistance syndrome can occur late in life because some what receptor she had all are exhausted, or some over which she had all are exhausted. Premature menopause or ovarian insufficiency, what we say, is a very well-known cause of secondary amenorrhea. Autoimmune disease, which occurs mostly in females, surgical removal for whatever reason, and finally radiotherapy if you are not taken care of. Masculinizing tumors are very rare. Gynandroblastomas can give rise to secondary amenorrhea very early. After ovary, we have no choice but to go up to pituitary, Simmons disease, Sheehan syndrome after a postpartum hemorrhage, panhypopituitarism, hyperprolactinemia, that is macroadenomas, adenomas and Cushing's, empty cellular syndrome, drugs, tranquilizers, COCs, dopamine blockers, antidepressants, antihypertensives, whole lot of drugs. So etiology-wise, hypothalamus, GnRH deficiency. After pituitary, we have to go to hypothalamus only. GnRH deficiency, it can be because of vigorous exercise, brain tumors, post-pill amenorrhea. Now you have to look outside the whole genital system or reproductive system. Nutritional causes, anorexia nervosa, excessive weight loss or gain. And then extreme obesity can also cause secondary amenorrhea. Suprarenal, Addison's disease, adrenogenital syndrome, suprarenal tumors, thyroid, the cousin of the pituitary, FSHLH, hypothyroidism, Graves' disease, and totally other causes like diabetes, tuberculosis, in general, not just a genital, liver disease, renal disease, because estrogen is metabolized in liver and secreted or excreted to the renal system. Severe anemia. So to summarize the etiology, if I start from above now, earlier I went from below. Either way, you should not be confused. Hypothalamus, tumors, exercise, weight loss, FSH will be obviously low. Clinical diagnosis can be made, but MRI CT will help. Pituitary, Sheehan syndrome, low FSH. Diagnostically, FSH and GnRH stimulation. Ovary, dysgenesis, surgery, radiation failure, obviously FSH is very high. Do a karyotype and biopsy. Anovulation, PCOS, hyperprolactinemia, weight loss, stress, and drugs. FSH may be normal or low. Progesterone challenge will solve the problem, ultrasound and CT MRI. Uterus, Asherman's, TB, radiotherapy, normal FSH, ultrasound MRI will reveal the diagnosis. also hysteroscopy. Outflow tract, cervical stenosis atresia, normal FSH kit, clinical diagnosis or ultrasound. What investigations? Rule out pregnancy first, because that is there in the definition itself. Elevated prolactin levels also should be ruled out because that is one of the known causes of amenorrhea. CT, MRI, visual checkup should be done if it is elevated. Decreased estrogen levels less than 40 picograms, you can do a progesterone challenge test. Positive, that means estrogen primed uterus after giving progesterone and withdrawing will bleed. But if it is negative, that means you have to give some estradiol and see. In spite of that, it is unresponsive, then it means the endometrium is totally destroyed. FSH, low means Sheehan syndrome, high means premature menopause. Treatment, hyperprolactinemia, cabergoline, PCOS, COC, or progesterone withdrawal or ovulation induction if it is infertility. Sheehan syndrome, clinical cyclical hormones is the only answer. Nutritional cause, you have to correct it. Post-pill amenorrhea, change over to high-dose COC and then withdraw. Drug or stress-related, reassurance is enough. Medical diseases, appropriate treatment of the disease. Premature menopause, menopausal hormone therapy. Thank you very much, and I hope you understood both primary and secondary amenorrhea well. It's very, very easy. You don't have to think much. Thank you very much for your patient listening.